Welcome to our podcast, Heart Failure Morning Commute. More heart failure drugs, more choices. Morning Commute is developed in collaboration with At Point of Care and Projects and Knowledge and is part of a continuing medical education series. This independent CME-CE activity is supported by independent educational grants from Boehringer Ingelheim Pharmaceuticals Incorporated and Eli Lilly and Company, and from Merck Sharp and Dohme Corporation. In this episode, Dr. Deepak Bhatt and Dr. Javed Butler discuss the many therapies that are now available for the treatment of heart failure, who are the best candidates for these medications, and what potential side effects to watch for. Information about the faculty and disclosures can be found at morningcommutepodcast.com/heartfailure5. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Bhatt is Executive Director of Interventional Cardiovascular Programs, Brigham and Women's Hospital Heart and Vascular Center, and a Professor of Medicine at Harvard Medical School, Boston. Dr. Butler is Professor of Medicine in the Department of Medicine at the University of Mississippi, Jackson. I am Candace Hoffman, Managing Editor of Morning Commute. Dr. Bhatt will begin our discussion.
David, welcome back. There are quite a few new therapies that are important additions to our heart failure armamentarium. Let's take a look at these and how they might be integrated into heart failure management. We've discussed quite a bit already about SGLT2 inhibitors, though it's certainly worth talking even more about them. They're really a major advance in the world of heart failure. We've talked about, and we'll talk about a little bit more, mineralocorticoid receptor antagonists. We should talk about ARNI, that is angiotensin receptor and neprilysin receptor inhibitors. We've talked a little bit about those already. And then we should discuss soluble guanylate cyclase stimulators and cardiac myosin activators. So a lot of stuff to cover here, not to mention how to integrate them all. But do you want to just quickly review for the audience what these key classes of medicines are and how they fit into current practice?
Yeah, we'll be delighted to. So, we are sort of in patients with heart failure and reduced ejection fraction, which, as we discussed, that concept is almost sort of now extended from the traditional 40% or less all the way up to less than 50%. We sort of think about foundational therapies that in the absence of contraindication or intolerance or accessibility issues should be really given to all patients. So at this point, I think most of the guidelines and the experts would say that in terms of the RAS modulation, valsartan, sacubitril, or angiotensin receptor neprilysin inhibitor is the preferred drug. Remember, it's one pill but two drugs, and we tend to forget that. So angiotensin receptor neprilysin inhibitor is not ACE inhibitor or ARB. I mean, it has been head-to-head compared against ACE inhibitor and heart failure with reduced ejection fraction with a substantially more mortality, morbidity benefit with ARNI on top of ACE inhibitor, and it's two separate drugs. It's valsartan and a neprilysin inhibitor, sacubitril. So in terms of the RAS inhibitor, that's sort of the first-line therapy. Then beta blocker, but again, evidence-based beta blocker. So carvedilol, long-acting metoprolol, or bisoprolol, not any beta blocker. Mineralocorticoid receptor antagonist is spironolactone or eplerenone, although more data with selective non-steroidal MRAs like finerenone is coming down the pike. And then the two SGLT2 inhibitors that have been approved in HFrEF, dapagliflozin and empagliflozin as well. So this is the foundational therapy, these four drugs. Then in some specific cases, we have some specific therapies. So for instance, on foundational therapy, if somebody is not doing well or is unable to tolerate foundational therapy and develop what we are calling worsening heart failure, which is either requiring hospitalization or recent hospitalization within the past 6 months, or requiring outpatient IV diuretics. So worsening heart failure. In addition to this foundational therapy, we have another alternative, a soluble guanylate cyclase stimulator called vericiguat. So this drug has a really sort of an interesting mechanism of action. Soluble guanylate cyclase is really sort of a ubiquitous mediator for improving cardiac, vascular, and other organ function through mediating the nitric oxide biology. So nitric oxide converts, in the absence of soluble guanylate cyclase, GTP to cGMP, and then cGMP have this down signaling for PKG all across the body. But in diseases like heart failure, where you have oxidative stress, your nitric oxide is really not bioavailable. So what this drug does, it has dual action. It increases the sensitivity of the soluble guanylate cyclase to whatever nitric oxide is available. But even if you don't have much nitric oxide available, it directly stimulates soluble guanylate cyclase to cause to increase cGMP production. So there was a trial done called Victoria trial that basically showed that in really high-risk patients, 35 to 40% 1 year event rate, this drug lowered the absolute risk by about 4.2% absolute risk reduction, 10% relative risk reduction for cardiovascular death, heart failure, hospitalization. So in those patients beyond the foundational therapy who develop worsening heart failure, we have this option as well. And then the last drug you mentioned, cardiac myosin activators like omecamtiv mecarbil, it increases the force of contraction of the heart. The trial was done. But this drug has not been approved, has not gone through the regulatory process. So it's not available in the market. It did hit its primary endpoint overall. It looks like the data are a little bit more convincing for those patients at the lower end of ejection fraction. So not only HFrEF, but even within HFrEF, those with ejection fraction that were on the lower end, say mid-20s or lower, tended to benefit a little bit more with cardiac myosin activators. So the jury is out a little bit on this as to what happens with the regulators, and it's not available in the market right now.
Yeah, that's a really nice summary. And with respect to these two latter drugs you mentioned, well, omecamtiv mecarbil, we'd have to have regulatory approval. For vericiguat, where do you see that drug being initiated? Do you see that as something that would be initiated as an inpatient, as an outpatient, either of the above?
Yeah, so that's a really sort of an insightful question, right? So we are trying to target worsening heart failure biology, and whether somebody's in the hospital or gets outpatient IV diuretic, those are sort of healthcare and clinicians' decision of where somebody gets treated, but that's nothing to do with the biology. So the biology here is that you're sort of failing on the therapy on which you used to be stable. Now that failing may be because you have taken everything that you possibly could, or you've taken everything that you can possibly tolerate. So even if you're not on some medications, which are foundational medication, but it's because your creatinine, your blood pressure, your potassium, whatever, your clinician is not comfortable giving you more than what you are. So in those patients that are sort of failing these standard therapies, then regardless, if you are reaching out to give outpatient IV diuretic, send the patient to the emergency room, admit the patient for decompensated heart failure, those are the kind of patients where this drug is available in the market right now, and I would consider giving it to them. Now, interestingly enough, this biology, this trial, Victoria trial, was done in worsening heart failure patients because we are targeting the highest risk population. But this target is equally suitable to less sick patients as well. You don't have to have worsening heart failure to benefit from this drug. But of course, we need a trial to prove that. So there's a large outcomes trial going on, more upstream in more stable heart failure patients. But today, if you are failing, and by failing, I mean symptomatic, you're just not doing well on your standard medical therapy, giving vericiguat is a pretty reasonable opportunity.
And anything to watch out for by way of side effect?
Yeah, so that's another very insightful question, because that is sort of the value add here. So first, vericiguat was given to the lowest eGFR patient population of any heart failure trial ever done. So it went down to GFR of 15. So really down, even more so than the SGLT2 inhibitor trials, because these are the patients who are not only the sickest, not only the ones most likely to develop worsening heart failure, but are the ones where people shy away, appropriately so, with other RAS inhibitors. In fact, MRAs are contraindicated in GFR less than 30 as well. So what's interesting is that if you look at all the reasons for which other medical therapies for heart failure sometimes are not tolerated or not given. So hyperkalemia, not an issue with vericiguat. Blood pressure, very well tolerated. 90% of the patients in the trial got to the maximum dose of 10 milligram. And again, blood pressure remained pretty stable all across the trial. no changes in creatinine, and the benefit was seen across the spectrum of GFR in this trial as well. So all the reasons for which other medical therapies are not tolerated, this drug is very well tolerated. So safety profile is actually one of the strengths of this drug.
Yeah, those are great points. Similarly, with respect to heart rate, and a patient who might already, say, be on a beta blocker and have a lowish heart rate, this is a drug that could be added on in that circumstance as well for the patient that needs more heart failure therapy. So you're right, the side effect profile really does align nicely with drugs that are already available where you need to do more for that particular patient. How would you integrate these different therapies into current practice? I've got to say, the data I've seen for all these different agents, maybe not so much beta blockers in ACE or ARB at this point in time, but certainly for ARNI and SGLT2 inhibitors and even MRAs. I mean, spironolactone is available, of course, as a generic, but for all these classes, there's still a lot of underutilization. Every registry has shown that. I mean, a lot of work even you and I have done together with the American Heart Association, get with the guideline heart failure registry. It's just, it's been persistent over years. There's a lot of underutilization. What do you think can be done to improve the implementation science of things here?
Yeah, so boy, I mean, that's sort of the really, really important points that you made, Deepak. You know, so medicine is a two-front war, right? So, you know, on one front, you have to generate evidence to know what to do to the patient, but on the other hand, you also have to then do it in order to have our patient population benefit from the therapies. And I think we do pretty well on the first in terms of the evidence generation, but unfortunately, we don't do too well on the other side of implementing these therapies. And even if you look at recent data, so the one data that I really, really like to quote is the Champ Registry. And the reason I like to quote Champ Registry is, one, it's very contemporary. So we're talking about 2018 data. It was across 150 sites across US. So academic sites, private practice sites, cardiology sites, primary care sites. So really a good broad sort of a perspective. Outpatient, but these sites actually were interested enough in heart failure to participate in a heart failure registry. So this is now a captured group of people. And we specifically asked them that if there is any contraindication or intolerance, please let us know so that we can have a pure denominator. And what did we find in over 3,500 patients? What we found was that triple therapy, so this is just a tad bit before the SGLT2 inhibitor. So we're talking about triple therapy, RAS inhibitor, beta blocker, and MRA. Triple therapy was used in less than a third of the patient, in fact, less than a quarter of the patient. And triple therapy at appropriate doses was used in single digits. So there's a 90+% opportunity of not getting on appropriate doses of all drugs, and 75% plus patients were not on triple therapy. Of course, we can imagine what quadruple therapy will be. The point I'm trying to make here is that these kind of gaps are not explained either by cost or by tolerance. Now, we have been, using all generic drugs in heart failure for a long time, ACE inhibitor, beta blocker, and MRAs. Now we have two drugs which are costly, right? SGLT2 inhibitors and ARNI. But let's first get the science correct. Remember, ACE inhibitors and beta blockers were not generic at one point, and SGLT2 inhibitors and ARNIs will become generic in the future. So, while cost is an incredibly important consideration, let's first get the science right. And the science is that we need to give 4 drugs that affect 5 pathways to improve outcomes, which is SGLT2 inhibitor, MRA, beta blocker, and ARNI to these patients. So then the next question is, how do you give these drugs? Now, sequencing has a historical construct, not a biologic construct. It is history of medicine that in the 1980s, we tested ACE inhibitors. In the 1990s, we tested beta blockers and MRAs and ARNI. In 2018, we tested, SGLT2 inhibitor. That is history of medicine. There's no reason to believe that you have to prime the heart by giving first drug, this drug, and then the drug will work. In fact, we actually have data that if a drug works, then irrespective of what other drugs you are or are not on, the drug will still benefit. We also know that the most benefit you get is at the low doses, but of course go on higher doses because there is an incremental benefit, but the most benefit is at low doses, and dose is not an issue with SGLT2 inhibitor, it's just one dose. And it's kind of not an issue with MRA also, 25 milligram perhaps is good enough, but it is an issue with beta blockers and ARNI therapy per se. So now the thought process has completely changed. We don't focus on sequencing at all. Why don't we do it? Well, because it takes months on end to go through that sequencing process, and the benefit from these therapies is really early, so we put our patients at risk. But this is one of the reasons why we drop the ball and why there are so many opportunities. At the end of the day, when somebody comes in with MI, and I realize that inpatient is different than outpatient, but we start 5-6 classes of medication in 3-4 days, right? So why does it take so long? So right now, the recommendation is to get all 4 drugs on board as soon as possible in 2, 3, 4 weeks, at least at low doses, cover all the abnormal pathways, and then slowly go up on the doses of ARNI and beta blockers as needed. Now, a lot of our colleagues are using the word not sequential, but simultaneous, and that is sometimes misconstrued, the word simultaneous. So nobody's saying that you start Mrs. Jones on 4 drugs on Thursday at 12:35 p.m. all at the same time. By simultaneous, the idea is don't worry about sequencing on a weekly basis or whatever. In 2, 3, 4 weeks, get all the medicines on board.
Really terrific information there. A lot that I think will be very valuable to the audience. Any tips about getting these drugs actually approved and paid for? Obviously, with drugs like beta blockers, that's not an issue. But ARNI, for example, there have been some issues, at least in some places I know, getting through these painful pre-auths and getting the patient the drug that they actually need. Any tips on how to navigate all that?
Yeah, so I mean, this is a big issue, right? I mean, clinicians are really busy. They have busy clinic. They have sort of the rapid turnaround, maybe 15 minutes with the patient, and these things become sort of really difficult. In our clinic settings are not necessarily set up with infrastructure and support to help us with this. The American College of Cardiology had a document called ECDP, Expert Consensus Decision Pathway, and that does deal with a lot of these things and how to help with pre-authorization. Obviously, there's a lot of differences and lots of colors and flavors to this thing based on your local insurance market, and even that changes depending on what sort of insurance you have, even within the same insurance company. So, I mean, my best advice would be to talk to your sort of local reps, because whatever the offerings are in terms of vouchers or other means of support with these therapies and help with the insurance companies, I think they probably have the biggest tab. Now, if you look at some of the data that are quoted to me, is that X percentage of patients, whatever, 70-80% of the patients may have coverage for this drug or that drug. But just because they have coverage doesn't mean the patient can afford it, because sometimes co-pays of multiple therapies by itself becomes a little bit of a problem. But again, it's important to have shared decision making. I think patients should be engaged in the decision. I think we owe it to the patients to tell them what are the therapeutic options, what are the potential benefits, what are the costs, and engage the patients and not necessarily decide for the patient of what they can or cannot pay for or use. But I think this is an issue that we're dealing with at a societal level.
Terrific. And maybe we can just end with a brief discussion of what is going on in the world of devices and what trials to watch for.
Yeah, we thought about devices as sort of really end stage care, right? So left ventricular assist devices and temporary devices like, balloon pump and impellers and whatnot. But boy, the device things have really sort of evolved. So traditionally, we have already had, defibrillators that we give to patients and cardiac resynchronization therapy or biventricular pacemaker. But there are so many other devices out there, sleep apnea, cardiac contractility modulation, baroreceptor stimulation. All of these devices have been approved, and there are more trials going on, including outcomes trial with these devices and other devices for autonomic modulation. There are devices for reshaping the heart. There are devices for reshaping the mitral annulus. So besides sort of, the aortic valve and the mitral valve clips, there are other ways to sort of prevent worsening of the valvular heart disease. So this is a really exciting area. We don't have enough real estate left on the heart to put more wires in, but so we'll have to sort of figure out how we are going to deal with these multiple devices, but a really, really robust field, which is growing right in front of our eyes.
Well, there's always wireless technology. I'm sure we'll figure out a way of stuffing in more technology. Well, we're out of time. It's been a great discussion with you as always. For the audience, I just ask you to stay tuned for our final podcast in this series, where we will discuss decisions in the management of heart failure and cover lots of interesting topics, including the one topic we always must cover these days, COVID. So please make sure to tune in for that episode. Thanks so much for listening.
Thank you for joining us today. Remember, to receive your credit and evaluate this program, please visit morningcommutepodcast.com/Heart Failure 5. Look for all of our podcasts on your favorite podcast streaming services.